Good morning, ladies. We received a new admit yesterday from Emerge into room 20. He is a 67-year-old male, an R1, who suffered an ischemic stroke. He received TPA in the trauma room and has since been transferred to us for further observation and ongoing care. Emerge reported an elevated blood pressure of 185/105 upon admission, but has since stabilized. He was recently diagnosed with hypertension, and his wife states he is being transferred or treated for depression related to his retirement 2 years ago.
Upon assessment, the patient is alert and orientated ×3. His pupils are equal bilaterally and reactive to light. He is responsible to verbal stimuli and is able to follow commands, but his speech is slurred and he is drooling as a result of the left-sided hemiparesis. He is experiencing mild dysphagia. His skin color is appropriate to his ethnicity, intact and warm to touch. Capillary refill is automatic and no signs of edema are noted. Oral mucosa is pink and moist. He denies visual disturbances, no previous history of head trauma. Upon auscultation, S1 and S2 heard throughout all sites. Radial and pedal pulses are faint and irregular but equal bilaterally. Patient denies having any chest pain, family history of heart disease. Currently on beta blockers. Patient states that they make him feel tired and dizzy. Upon auscultation, clear breath sounds heard in all lung fields. Respirations are unlabored, and he is currently on 2 liters of oxygen, and his SpO2 is 91% with a nasal cannula. He is a moderate smoker. Wife states he smokes about 10 cigarettes a day, but is denying any shortness of breath. Hypoactive bowel sounds noted in all 4 quadrants. No masses, distension, or tenderness noted upon palpation. His last known BM was yesterday afternoon. He's experiencing no difficulties with voiding. He requires a 2-person assist to the commode as his ambulation is impaired due to left-sided hemiplegia. His urine is yellow and clear. Since his time of admission, he's had an output of 800 milliliters. We will continue to encourage intake of oral fluids, though the patient states he is not a fan of water. Limited range of motion to left side, hand grips are unequal bilaterally. He has an unsteady gait noted to bilateral leg weakness. His wife states he has been dealing with depression since his retirement in 2018, often feels frustrated and useless, feels he is a burden to his family. He is of Christian faith, so the wife has been notified that a chaplain is available upon his or her request for added support.
The physician ordered a head CT and an angiogram. Vitals post-op or post-TPA have since stabilized. We're currently reassessing every 4 hours. The last known CBG was 5.8 and needs to be retaken. Physician has ordered heparin 0.5 milliliters sub-Q injection every 12 hours, aspirin 81 milligrams once a day at 0800, and lisinopril 10 milligrams once a day at 0800 as well. Blood work was completed and showed concerning elevation of cholesterol and LDLs, as well as severe stenosis at 70%.
Regarding his care, we have assessed his level of ability using the Barthel Index Scale, which showed he is at risk for permanent decreased musculoskeletal function, as shown by his score of 60 on the Barthel scale. We are hoping to increase his overall score to 90 by his tentative discharge date. We are suggesting that physio and home care be consulted to create a plan of action to increase ambulation and regain musculoskeletal function to his left side, and to assist the patient with contacting the rehab department to schedule weekly follow-up appointments once discharged to increase ambulation and regain his musculoskeletal function to his affected side. Our plan is also to question the patient on his expectations regarding recovery and ensuring that he feels included.
While he's here, we're also doing our best to ensure he is successfully communicating his needs to both us and his family members. We've given him a whiteboard to assist in when verbalization is unsuccessful. Morning shifts are currently encouraging 10 minutes of verbal communication to improve speech, while making a point to allow him appropriate time to answer in order to avoid frustrations. Let's make sure we're acknowledging his feelings of frustrations and that it's challenging for him right now. We're also hoping to increase his improvement in communication by 40% by February. We need to assess the degree of dysfunction and consult the speech language pathologist to determine a plan of action. And we also have to assist him in pre-arranging weekly appointments with the speech therapist. Another concern is his low self-esteem and depression. We're addressing this by encouraging self-care rituals and providing positive feedback with efforts and educating on the effects of negative self-talk. We're also encouraging community resources such as counseling upon discharge.
There's some things I wanted to quickly discuss. So Mr. Williams has shown some ineffective coping related to his decreased mood. And we can see this in an increased consumption of high-calorie foods such as fast food, an inability to perform basic needs such as cooking. He's had some recent weight gain. He's not communicating his health concerns with the nurse, and he's been smoking. So he's expressed some interest in learning some coping mechanisms. So I'm going to teach him those today, and then I want to see him demonstrate them by the time he's discharged. So let's try to assign him the same nurse to facilitate the development of the therapeutic relationship. Can you check in on his moods at least once an hour? Probably while we're doing comfort rounds. I'm hoping we can keep a close eye on his mood so we can intervene as fast as possible. We should try to spend as much uninterrupted time with him as possible to further develop the therapeutic relationship and identify factors that decrease mood. I know he's having some mobility issues, so let's start out doing more care than is necessary and then slowly encourage independence. That way we can give him the necessary support and we'll slowly boost self-esteem. The coping mechanisms I want to teach him today are encouraging him to talk about his feelings with his family, and encouraging him to express his emotions with the nurse. Let's try and establish a daily routine with adequate nutrition and sleep. And there's some relaxation techniques such as deep breathing, guided imagery, and distraction. We'll see if maybe we can get him some puzzles or a working TV. And then I just want to make sure he's able to learn first before I teach him these, and then have him repeat them back to me. He can pick whichever ones he likes the best. They're really important because they make a positive impact on the way conditions are perceived, the severity of the symptoms, and on the psychological stress associated with them, especially since he's just had a stroke and that's going to change his life very drastically. Also, I want to set up a consult with a mental health professional, someone he can talk to while he's in the hospital and after discharge. He can get some help with his depression and the stress that'll probably be brought on by his recent life changes following his stroke. With that, I will do some education on what psychotherapy can do and like psychiatry can do to help with feelings and resolving real-time problems, and then educate him on the benefits and the importance of seeing a psychiatrist because it's been shown to improve mental health problems such as depression. And then I really want to quickly talk about discharge planning. He's been having some mobility issues, so we'll consult to occupational therapy and physical therapy, and then maybe home care to help with that coccyx wound. AM dressing and PM undressing, and to shower once a week. We'll consult a dietitian about his difficulty swallowing and his bad diet lately, and then again to psychiatry. We'll teach him about stroke prevention, taking all his medications as prescribed, eating healthy food, and exercising regularly. We'll try and get him to quit smoking, offer some resources for this, and then the signs and symptoms of a stroke. So numbness or weakness on one side of the face, an arm or a leg, confusion, difficulty speaking or understanding, difficulty walking or bad coordination, severe headache, and that he should go to the hospital if he's any signs of these symptoms, any signs or symptoms of this. And then teach him about his medications. He's on enalapril, so it's an antihypertensive. So we'll teach him about how high blood pressure can lead to a second stroke, which isn't that uncommon when you've already had one. We'll let him know to decrease the amount of salt in his diet with this, that it can cause some dizziness, what to contact his doctor about. And then he is also on Apivaxin. So we'll tell him it's a blood thinner. It prevents clots that could travel to his brain and cause another stroke. He has to take this medication as prescribed, that it can cause bruising or bleeding, and to inform his doctor of any unusual ones, like from the gums, the nose, in the urine, or the stool. And then Pravastatin, which it'll lower his cholesterol, which is important for preventing strokes, as fat can build up in arteries and veins, cutting off blood supply. He shouldn't take this with grapefruit juice, and he should wear sunscreen with it. And I think that's all I've got.
So based on the assessment findings that Bruce and I found, the patient is complaining about a 5 out of 10 pain coming from his coccyx area when we wash him. And there's a pink unopened sore in his coccyx area. The diagnosis that we found is that he is at risk for impaired skin integrity, which is related to his physical immobility. Short-term goal we have in place is that the patient will experience improved comfort, and the nurse will observe wound healing around the coccyx area by using objective data. This is evidenced by self-reporting a 3 or less out of 10 on the standard pain scale. The nurse will also be able to see if the wound is healing. This goal is attainable by making sure that they rotate the patient every 2 hours and applying barrier cream to alleviate the pressure on the coccyx area. This goal is realistic because the patient is unable to maneuver by himself, and rotating him will relieve the pressure on his coccyx area. Knowledge about his diet will influence his skin integrity, and it'll be more beneficial for the wound healing. This goal will be met daily up to and including the discharge date. An intervention we have in place is that the nurse will rotate the patient in bed every 2 hours to alleviate the risk of the pressure sore on coccyx area from opening. This goal will be met daily up to and including the discharge date. The nurse will change positions in bed every 2 hours since he's unable to maneuver himself in bed. This will help keep the blood flowing, which as a result keeps the skin stay healthy, and it also prevents bed sores from occurring. Our second intervention, the nurse will apply a skin barrier cream every 48 hours as needed to help aid in the prevention of the pressure sore on coccyx area from opening. The barrier cream will be applied to the coccyx area to help keep contaminants away from sensitive areas that will prevent the growth of bacteria in open sores. A third intervention we have is that the nurse will schedule an appointment with a dietitian 2 days from now to educate the patient about proper nutrition, the importance of staying hydrated, and more methods that will help improve skin integrity. This intervention is useful because certain nutrients help the cells in your skin regenerate, which will make them less susceptible to skin breakdown that can be caused by the sun, immobility, and other environmental factors. Based on the evaluation, our goal was fully met. The patient states, "My butt doesn't hurt anymore when you perform my care. All that moving around sure helped." Mr. Williams rates his pain as 0 out of 10 on the standard pain scale, and goal was met by his discharge date. The coccyx area is completely healed based on nurse's observations, so again, that objective data. The site is no longer red, inflamed, or bruised. Teaching is provided to Mr. Williams and his wife. The nurse suggested that Mr. Williams still rotates frequently to prevent the sore from appearing again. Barrier cream has been sent home with his wife in case the wound starts to become reddened or sore. And then a long-term goal is that the nurse will monitor the coccyx area as well as home care once he is discharged for any increased redness, warmth, swelling, pain, or any other signs of infection. An end goal is that he will continue with these practices to prevent the pressure sores from occurring again. This will be measured on the nurse's and home care's observation of the wound healing process. This goal will be attainable by making sure the nurse is documenting the wound healing process daily to make sure there's no decline, and that goes for home care as well. This goal is realistic because hygiene practices are crucial when it comes to wound healing, as well as the patient's overall well-being. The goal will be met daily up to including the discharge date. So an intervention we have for that is that the nurse will monitor the status of wound healing on the coccyx area and observe the patient's skincare practices, taking note of technique, frequency, items used, and how thorough the patient is. Nurse's observations will decide if the goal has been met by the patient's discharge date. The nurse will provide Patient teaching to ensure proper techniques will be used to aid and help in the wound healing and to prevent further wounds. The second intervention, the nurse will consult with home care to go over proper hygiene techniques to ensure that the patient's skin integrity will be made a priority in their care. The nurse will be responsible for communicating with other healthcare professional teams to go over hygiene practices, since effective teamwork can immediately and positively affect the patient and safety outcome. Our goal was partially met based on the evaluation. Patient teaching was provided on hygiene practices. The patient states, "I didn't know that fully drying my areas after a bath can prevent this from happening again. Now that I know this, I will be sure to dry myself better." Based on observation, the patient often forgets how to use the proper cleaning technique, and it appears to be rather rough when he is washing himself. The wife has been made aware that she may have to remind him or prompt him that just to be more gentle and to thoroughly dry his areas before getting dressed. This is because the nurse noticed that he forgot and left the coccyx area slightly damp as we assisted him with putting his clothes on. If this goal were fully met, the patient would have successfully been able to complete the suggested hygiene practices, and repetition will be necessary moving forward to ensure that he's washing himself correctly to maintain that skin integrity. The nurse has consulted with home care about hygiene practices and how to properly maintain Mr. Williams' skin integrity, and barrier cream has been sent with home care as well when they visit.